So hi everybody and welcome officially to the first session of the International Deprescribing Journal Club. We'll let people keep entering as we start a slow introduction to the session. This International Journal Club is a collaboration between the Australian Deprescribing Network, the US Deprescribing Research Network, the Network of European Researchers in Deprescribing, the European Society of Clinical Pharmacy, and the Canadian Medication Appropriateness and Deprescribing Network. So really to begin with, we want to thank all of these groups for their efforts in collaborating us with a great deal of effort that went into planning this session. So the agenda for today, we'll start with a bit of welcome and introductions and some housekeeping. We'd like to get to know a little bit more about people who are attending today. Soon we'll be starting the presentation portion, and then it'll be followed by a question and answer session. At the end, we do have a survey to see what you thought of the Journal Club and to help us to improve it. So if you're able to stay until that last slide and complete that survey, that would be really helpful for us. So I guess we can say that, a large group of researchers and clinicians from different continents and all across the globe thought that we needed a way to connect and discuss ideas and recent prescribing publications and complex clinical cases. And so this is really how this journal club was born. Our goal is to foster connections and collaborations, as well as to share really the latest research that's occurring in deprescribing and how it applies clinically. So it's great to meet you all. I'm going to be chairing today's journal club. My name is Emily McDonald. I am an internist at McGill University Health Center and an associate professor. I'm the scientific director of the Canadian Medication Appropriateness and Deprescribing Network, also known as CADeN, and I am very excited to see so many of you online today for this inaugural session. So just as a reminder, a bit of housekeeping before we get started. To help us ensure that there's good audio quality, please keep your microphone muted. You can, however, unmute to ask questions during the Q&A period, and you're encouraged to do so. Because not everyone is able to attend live, and especially because we're really coordinating this around the world across many different time zones, we will be recording these sessions. And so please note that this recording will be posted on CADeN YouTube channel later today. Additionally, our speaker has kindly accepted to share the PDF of the slides. And so those will be made available on our website at deprescribingnetwork.ca under the Journal Club session. Finally, in terms of Zoom, during the presentation, you may have questions, and we encourage you to have many questions. That's why we're here. We do have a good amount of time at the end, about 15 minutes for Q&A. If you want to remember your question, you can enter it into the chat function. We'll keep track of them and we'll bring them up at the end. And then during the Q&A, you might want to share your thoughts or discuss verbally. And so we would ask you just to raise your hand, and when you're called upon, you'll be able to speak directly to the group. So we will start with our first poll. And so we really want to know a little bit about where everybody is geographically located today. So we will launch that. I think, oh, great, thank you. Are people able to, yes, okay. We have one person. There we go, okay. So it looks like today we really have a kind of almost 50-50 split between Europe and North America attending live. So I think we can end that poll. And we will go on to the next poll. So we're interested also in whether or not people are clinicians, researchers, members of the public, trainees, or a mix. So we'll launch that second poll.
Emily, I believe the questions were all in this first poll. I don't know if you're able to see, but it was all in the intro poll.
Okay. Thank you.
If you're able to go back, you can hopefully see these results.
I see them. Thank you.
Excellent.
Okay, so we have a mix of clinician researchers. We have one trainee, no members of the public, some people who are identifying as other. So really like a very nice mix of different backgrounds here. And most people here are here to learn about new deprescribing literature. Some are ready for a debate and for some fun, so that's great. Okay. So without further ado, let me introduce the speaker today. So Louise Papillon-Ferland obtained her bachelor's degree in pharmacy from the University of Montréal in 2001 and completed her master's degree in pharmacy practice in the hospital pharmacy option in 2002. She completed a specialized residency in geriatrics at the McGill University Health Center, that is where I met Louise and where we worked together, and at the Montreal Geriatric University Institute, UGM. In 2004, she started practicing at the MUHC, where she participated in the implementation of the elder-friendly hospital approach. So in 2019, sadly, we lost Louise from the MUHC, and she was appointed assistant clinical professor in geriatrics at the Faculty of Pharmacy, so lucky Université de Montréal, and joined the team at the IUGM, where she's clinically involved at the ambulatory geriatric clinic, assessing patients, so really working on the ground, seeing patients with geriatric syndrome, addressing polypharmacy every day in her day-to-day practice. She's a clinical professor affiliated to the Michel Saucier Chair in Pharmacy, Health and Aging, and she's also a member of the Pharmacist Experts in Geriatrics Committee of the Quebec Health Institutions Pharmacists Association. So welcome, Louise, and I will turn things over to you.
Thank you very much, Nini, for this intro. So I'll start now so we have time for comments and discussion at the end. So just before starting, I just want to say that I don't have any conflict of interest with the presentation today. And a quick reminder of the objectives that you saw in the advertising, but the goal today is to present the learnings from the optimized trial and to discuss enablers and barriers of deprescribing. And I will present you one case I had at the geriatric clinic, so we can do some parallel and open discussion on that. So let's start with the case. So I will present you Mrs. M. So Mrs. M is a lady that I'm following at the geriatric clinic. So she's 84-year-old. She was referred by her family physician for a geriatric evaluation. She's living alone. She's a retired patient attendant, and she has support from her friend. And I'm being consulted basically because for a global medication review, she has a polypharmacy and probably some compliance issues. So it's a lot of my patients that I see that I'm being consulted for that reason. So she's known for a mild neurocognitive disorder, maybe at the limit of a major one, but for now, her diagnosis is a mild one. She's also known for hypertension, anxiety, depression. She had a hip fracture 1 year ago, and she has chronic pain issues, mainly from osteoarthritis. And she's already followed by multiple healthcare professionals. She has her family physician, but she has also 5 other specialists involved in her care. She has a geriatrician, but she has a pain specialist. She has a gastroenterologist, so she has other multiple physicians. So let's now look at our medication list from her pharmacy. So if we look quickly, she's on telmisartan and amlodipine, like antihypertensive. She's on an antidepressant, the bupropion. She's on clonazepam and lorazepam, so some benzodiazepine. She's on beta-histine, sometimes given for Meniere disease, but often given for unspecific dizziness. She is also on some eye drop for glaucoma. She's on oxycodone regularly. She's on a PPI. She's on antispasmodic decyclomine, some diminuginate, lactulose, laxaday, and an antibiotic as needed for urinary tract infection. So maybe just to get some fun at the beginning, without knowing, I agree, still a lot about her, could you identify some of the potentially inappropriate medications in our list that you would consider possibly for Deprescribing? So I will launch this poll and you can choose whatever, how many answer you want. You can choose all of them if you want. I'll leave a few seconds, then maybe I'll share what people answered. So actually, we have choices for all the medications. So are they all potentially inappropriate? It's sure that it depends of the situation of the patient, and we'll need a bit more info for that. But I can see that the most common chosen potentially inappropriate medication are benzo, clonazepam, the lorazepam, the opioid, the PPI, and some gravel, and also the beta-histine. So I'll stop the sharing and we'll go back to that. So now we'll get back to the case, but then we are here today to discuss about the optimized trial. So let's start with this one. It's a study that was published in JAMA Internal Medicine this year, and it was funded by the National Institute of Aging. So the rationale for the study is that patients with a neurocognitive disorder or mild cognitive impairment are down with multiple chronic conditions and multiple medications. And we know that these can lead to an increased risk of adverse outcomes, so polypharmacy and leading to adverse drug reaction, cognitive impairment, falls, hospitalization, etc., etc. So the question is, does Deprescribing help with that issues? There was already some data with a neurocognitive impairment patient, for example, in nursing home or in hospital or on specific class, but less on a primary care patient. So the authors of the optimized study, they did some preliminary work, some qualitative study to try to establish what would be a good intervention for these patients. And the elements that were identified by interviewing caregivers, patients, and physicians and healthcare professionals was that there was some key elements to facilitate Deprescribing in primary care for patients with cognitive impairment. So the first one was to establish trust. So this is very, very important. The second one was to frame Deprescribing as a positive or routine habit, so not something that happens suddenly and that it can be disturbing. After, it was to align Deprescribing with goals of dementia care. So as progressively as we go towards symptom management, to try to align the goal of medications to the goal, the global goal that is evolving with the dementia progression. There was also the team about providing direct-to-patient educational materials, so adapted materials, and also materials that suggest language for the patient of what to ask, for example, to their healthcare professionals when they come to their visit. And finally, the last point that was suggested is that really we need to engage the entire healthcare team in the prescribing for these patients. So that was the preliminary work. We'll keep this in mind and hope that it was well implemented in the study. So the objective of the study was to examine the effectiveness of increasing patient and clinician awareness about the potential to deprescribe unnecessary or risky medication among patients with dementia or mild cognitive impairment. So for that, the design was a pragmatic, patient-centered 12-month cluster randomized trial. The trial was run from April 2019 to March 2020. So I don't know how much the COVID affected. I guess it was not easy, but it was the study period. And the hypothesis was, does a deprescribing intervention will lead to a reduction of number of long-term medications prescribed, or the percentage of a person taking at least one potentially inappropriate medications at 6 months. So they conducted the study in 18 primary care clinics. It's the study that was done in Colorado in USA. So there was 9 intervention clinics and 9 control clinics. The clinics were randomized using a uniform distribution block of 2 by clinic size. So the clinics would be aligned in terms of size of patients. And basically the control clinic were receiving the intervention in a delayed manner 24 months after the start of the intervention clinic. To be eligible, patients needed to be old, like 65 years and older, having a primary care clinician in the clinic that was targeted for the trial, being diagnosed with major neurocognitive disorder or mild cognitive impairment, have 1 additional chronic medical condition plus the cognitive impairment, and having polypharmacy defined as 5 or more chronic medications. There was no need for informed consent because it was evaluated that this was part of the, it was a pragmatic trial and that the medication changes were done at the end by the clinician, so the consent was waived. Patients living in long-term care facilities or enrolled in hospice care were excluded. And basically, patients that were included needed to have also an appointment to the primary care site 7 days, that is, was scheduled 7 days in advance, so they could be targeted for an intervention. So for the clinicians, they were involved if they were caring for adult patients in the clinic that was targeted for the trial. And the primary target was physicians. It could be family physicians, some were internal physician. There could be also other clinical staff as advanced clinical nurse that could be included if they were attending the primary care clinic provider meeting. So what was the intervention that was designed for this trial? So there was really 2 components in the intervention: patient and family and clinician. So it was really bringing together and targeting both for the intervention. And the aim was to promote education, through education to activate the clinicians and to engage patients. So both would be more familiarized and would be more willing to participate to the prescribing. So what they did, so the first component, the patient component, actually was consisting of mail materials. So basically, within 2 weeks before the appointment, patient would receive at home a brochure that was called Managing Medications. Could you benefit from taking fewer medicines? So it was a global brochure about medication optimization and the prescribing. And there was also another component of the patient intervention, is that it was the patient's attitude toward the prescribing questionnaire, the version for cognitive impairment. The only thing I should say is that this questionnaire asking for attitudes toward the prescribing, there was an envelope to return to the research team, but it was mostly for the research, but it was not given back to the clinician. So that was the first part of the intervention. The second part was the clinician component. So it was divided in 3 parts. So there was an education presentation at the beginning of the trial, and the physicians were also filling the prescriber perception of medication discontinuation assessment. So that's a questionnaire for the clinicians to help see how they address the prescribing with their patient. They were also presented monthly some tip sheets, and I have an example on the next slide. And the last component of the clinician intervention was an electronic notification. So basically, they were notified that one of their patients was mailed the material before the appointment. So this is an example of the tip sheet that was provided to the physician. So this one on the right was about Deprescribing to improve troubling symptoms. So for example, it seems to be like a practical trick to how to approach these issues with the patients and to better implement. And there was a variety of subjects like on Cascade, the treatment de-intensification, approach at the end of life, over the counter. So a variety of subjects covered over the 12 months. So now, what were they looking at outcomes? In the protocol, they were saying outcomes at 6 and 12 months. So the primary outcomes was the number of chronic medications and also the number of potentially inappropriate medications. So, and we'll see which ones were there because they looked at the Beers list, but it was only the section of medications to avoid in cognitive impairment, and they added opioids. So for the ones that don't recall this section of the Beers list by heart, so they were including anticholinergics, benzo, H2 receptor blocker, non-benzodiazepine and benzohypnotic, such as the Z-drug, antipsychotics, and they decided to add the opioids on that list. This was based on the 2015 criteria, so that was probably at the beginning of the design trial, but we know that in the last version of the 2019, the H2 receptor antagonists are not anymore on that section of the Beers. So regarding the secondary outcomes, they looked at outcomes that were a bit more clinical in terms of adverse drug events, ability to perform ADLs, admissions, and they also had plan to look at dose reduction and the number of potentially inappropriate medication that were started. So this is really the summary of the trial. So half of the clinics were designed to have the intervention. Half of them were just receiving usual care, but usual care patient actually still had some medication reconciliation done, and also had in their electronic health record some alerts that were already there regarding potentially high-risk prescribing. And an example given was a dose reduction for chronic kidney disease. So if we go to the result of the study, so basically they screened 11,000 patients that had either major neurocognitive disorder or mild cognitive impairment, 65 years old and older with another chronic condition. And when they excluded patients that didn't have an appointment during the study period, that were taking less than 5 medication, or for which the appointment was scheduled too short in advance, less than 7 days, that conducted to approximately 3,000 patients that were included in the study. And so half of them were approximately in the intervention clinic, and the other half was in the control clinic. Who were these patients? So they were relatively comparable between both groups, so the intervention group and the control group. So the mean age was around 80 years old, a bit more female than male, mostly being non-Hispanic white people. And they were in average on 7 medications, and approximately 30% had at least one potentially inappropriate medication, as defined from the list I've shown a bit earlier. So the proportion of patients with mild cognitive impairment was 22%. So that meaning that the majority of the patient had dementia diagnosed. And there was a proportion around 28 to 30% of the patient that received a second time the brochure, because if the patient had a second appointment to the clinic during the period of the study, they could receive a second time the brochure to help educate them. So which one, what were the potentially inappropriate medications that were taken by the patients in the study? So before giving you the answer, I would like you to guess. So what do you think of the class of medication that was the most frequently used? You can maybe select 2 if you wish. What would be the common medication?
Can you relaunch the poll, Min?
Oh, yes, sure. Relaunch. Yes, does it work now?
It's working now.
Good, thank you. So I see most of you have participated, so I'll end up the poll and share the result. So, so you think that the benzo will be the most frequent one, followed by some antidepressant, the anticholinergic ones, some overactive bladder, and not that much for the other classes. So we'll see if you were right in terms of what the patient were using. So basically, the kind of potentially inappropriate medication that were most commonly used, I've listed actually the 2 most frequent for each class, but when we highlight the very most frequent, so it was mainly opioids that seems to be quite frequent, followed by antipsychotics. Then we had also a lot of patients on trospium in the antimuscarinic, and also a lot of patients, but not as much, on benzo and H2 receptor antagonist. So of course, that will affect also how we approach these patients, because we cannot deprescribe these medications the same way often in clinic. So when we look at the results, now, for the primary outcome, we had the number of chronic medications. So at the baseline, we know that both groups were taking approximately 7 chronic medication. Both groups reduced a little bit, but it was quite similar between the control and in the intervention, so the difference was not significant. And it was a bit of the same pattern for the percentage of person prescribed at least one potentially inappropriate medication. So the baseline percentage was around 30%, and both groups had a reduction around 18 to 20%, but there was a small reduction, but that didn't reach a clinical statistical significant for the percentage of potentially inappropriate medication. So that were the primary outcomes. Then they looked at subgroup analysis in the results, and basically there was not real change in the results, either in the number of chronic medications and because they looked at does the number of medication change, like the baseline for patients that were taking more medication at baseline. Does it change regarding if patient got once or twice the intervention, like the mailing materials? We could have guessed that maybe receiving twice the material could help. But in my perspective, the reason behind that is also that in a primary care clinic, if a patient gets a second appointment in a short period, it may be because the medication will be reevaluated, but it's often because there is something unstable or medical issues to address, and sometimes it's not the best time to address for deprescribing. And the last thing that they looked at is that if there was a difference between Alzheimer's disease patient and malcognitive patient, and there was not a difference. There is subgroup analysis for the other primary outcomes, so the percentage of potentially patient taking at least one potentially inappropriate medications, were quite similar. Maybe there was a tendency for patients on a higher baseline of medication to benefit a bit more of the intervention, but the P4 interaction was still not that impressive. So the author's conclusion was that a large-scale education deprescribing intervention for older adults with cognitive impairment taking 5 medications or more long-term and their primary care clinicians demonstrated only small effect size, and that it did not lead to significant reduction of the number of medications and potentially inappropriate medications. So it was quite actually a sad thing in terms of the primary outcome. But in the conclusion, they bring up the possibility that such intervention should target older adults that takes more medication because of the subgroup analysis that they've done. So that's maybe one avenue, but we'll discuss about is there other things to consider. But before that, I would like to go back to the case of Mrs. M. So let's go back to her case. So first, would she have been eligible for the study? Yes, of course. She had cognitive impairment. She was an older lady taking more than 5 medication and having an additional chronic medical condition. So if I'm going back to what I've done with her, first, we need to be careful between the list that is available in a data file or a pharmacy file. And I started reviewing what was she really taking, so her real list, and it changed the picture a little bit. So finally, she was only taking 1 antihypertensive because she had stopped the first one when the second one was started. Her antidepressant, she was not taking anymore because she had started, but really didn't tolerate, was feeling dizzy, nauseated, etc. Regarding the benzo, she was taking only the clonazepam because, in fact, it was one of her physicians that tried to switch her to lorazepam, and she didn't really find that she was feeling well with the switch. She went back to the clonazepam, but in her list, both benzo were still there. The betahistine she was using occasionally and trying all sorts of things, I should say, for her dizziness. The oxycodone, she was trying a higher dosing, but only twice a day with a pain control that was not optimal. She was taking regular Tylenol that was not on her initial list. And the dicyclamine and diminuginate she was using still, not regularly, but she was using them. So that was my first thing to confirm her medication. I should say that she had a lot of multiple past intolerances to other medications. She was proposed a blister pack recently for the management of her medication that she refused because she wanted to stay autonomous and didn't see the need for that. So before deciding what would be the best in terms of medication management, as a clinician, I was, of course, missing some information. So there is a bit more info about Mrs. M, so about a bit of geriatric info. So in terms of autonomy and mobility, she was walking with a cane. She has a balance disorder with a reduced birth, and she fell last year. So she's partially dependent for her instrumental activities of daily living. She's managing her medications by herself, but needs help, for example, for shopping and finances. And she's managing her activities of daily living by herself, but I should say with some difficulties. There was a lot of issues regarding her nutrition. She had lost weight over the past year. She has a reduced appetite. She had frequent nausea, heartburn, and now she had a weight around 49 kilo with a body mass index that was not very high for an older adult at 21. In terms of cognition and mood during the interview, it was obvious that she was a really, really anxious person and that she had some mild memory impairment. Her sleep was good, so that was not an issue. She was even napping a lot during the daytime. And regarding elimination, she was chronically constipated, having urinary urgency also, but without incontinence. And the pain was a big issue for her, limiting her mobility and pain in the hip, the knees, the back, so pain. So really, she is a patient with probable side effects from our medications, causing her possible balance issues, the fall, maybe affecting her autonomy, contributing to the weight loss, maybe nausea, things like that, being constipated. So the thing that was not helping were also the adherence issues. She had a difficulty understanding the changes of medication, and she's certainly a higher risk patient, a frail patient that needs to be prioritized for the medication review. So the other thing that I've done with Mrs. M is that with the clinic with my colleague, we choose a certain question from the patient attitudes toward Deprescribing. We don't really have time for the original 20-something question that is quite long, but we still ask some of the question. So she was regarding taking a large number of medicines. She said that maybe she was taking only what's necessary. Regarding feeling comfortable with the number of medication taking, she wasn't sure. So to me, that means that she was not that comfortable with them. So regarding believing that all our medications were necessary, she was not sure at all. So there was a window there to do some reassessment. Regarding believing our medications were possibly contributing to a side effect, she identified herself the nausea. And finally, she was in agreement to reduce medications with an appropriate follow-up. So to me, those questions are quite helpful to understand their perspective, to understand the reason of what they think is necessary, what they have in terms of side effects. But unfortunately, it seems that this info was not transmitted to the clinicians in the study. So now, if we go further in time, so we looked at Mrs. M at the beginning, but just to give you a window of what happened over the 6 months. So at the beginning, we started by stopping her betahistine and the dicyclomine. She agreed they were poorly effective, and I explained her that they were probably contributing to adverse drug reactions, constipation, and some of her gastric symptoms. For the pain, we did a trial of a diclofenac gel, and I proposed a pill box, at least that she could fill herself, since she didn't want the blister pack filled by a pharmacy. So a month later, she was less dizzy, less nauseated, but still present. We tried to split her oxycodone, smaller dosing, more regularly to try to help with the pain. She was still constipated, so we adjusted the laxative. The topical gel of diclofenac didn't help, so we didn't keep it. So progressively over time, I continued the follow-up. She finally started using the pill box. And now, actually, she agrees to clonazepam reduction, which at the beginning was really afraid to do so because it was not, the switch to lorazepam earlier didn't go well. And but I was able to convince her because she was worried about the side effects in combo with the opioids. So I explained to her that it would be a good thing to reduce in that context. So we progressively reduced her clonazepam. There was some mirtazapine started at the same time to help with her anxiety. Then a bit later on, we continued the reduction. So she was on 1 milligrams, then 0.75 milligrams. In contact with her family physician, we started treatment for her osteoporosis. You remember she had a hip fracture last year that wasn't treated, still needed adjustment in her laxative. And finally, the pill box was not a good story for her. She had difficulty with the initial one she bought. We switched it, but still were able to continue the reduction of clonazepam. And now it's been 6 months I'm following that patient. She's on a much lower dosing of clonazepam, but the story needs to be continued. So if we look at the big picture, so at baseline, you had the list of what she was taking of actual medication. And 6 months later, so she's taking a lower dose of the benzo. She's not taking anymore the betahistine. The oxycodone, she's still taking. She has significant pain issues. She's still on the PPI because of her persistent gastric issues. We were able to stop the dicyclomine, and she's not needing the dimenhydrinate anymore. But we did some addition to our medication, so the mirtazapine, the laxative, and the osteoporosis medications. So to me, it was still a significant improvement in terms of anticholinergic load and potentially inappropriate medication. But if she would have been enrolled in the study, our total number of medications actually increased from the beginning. And for the other outcome of being on at least one potentially inappropriate medication, she was on, and she's still on some. So it would have been a change. So some reflections. We addressed a lot of challenges with Mrs. M, but it needed a lot of investment and over many follow-ups. Our initial resistance of the change of the benzo, we were able to build trust over time. And also we were able to deprescribe in the context of actual adverse drug reactions. So focusing on improving your balance and memory and things like this to be able to reduce her other medication. We tried to give her some medication. I had given some written info, but really it was not the best for her. Really, she needs repeated info over the different follow-ups. And I was also able to link with other physicians as needed to help with the coordination of the care. So you have a perspective of a clinician regarding that. So let's go back to the study and having some element about, and I divided them with the PICO to help the analysis. So the first one, if we look at the population included in the optimized study, they were really, they wanted to have a pragmatic real life study. So the inclusion criteria were quite broad with a large sample size. But I'm wondering, like for this kind of interventions, like should we select more complex patient or with more polypharmacy? Actually, this is one of the author's conclusion. Should we select higher risk patients, like with more comorbidities, or more frail patients, or with more geriatric syndromes, things like that? Then if we look at the intervention, I did targeted patients and clinicians really to have more education and empowerment of the patients. So that's a real good thing. But how come it didn't lead to a significant result? So I'm wondering, I mean, in a primary care clinic, if I'm looking at the time I spent with Mrs. M and compared to a primary care clinic, what is the time needed for these patients? Is it sufficient? Like 6 months in a primary care, sometimes it goes very fast if a patient doesn't have a specific follow-up that are planned. Also, the targeted patient for education, but it seems to be global info. So does sometimes we need maybe specific education materials that is adapted to the patient. I'm thinking, for example, patient education regarding benzo, and that includes specific non-pharmacological approach for sleep, as an example. Regarding the clinicians, maybe they need more support, I don't know, or for example, with coaching to be increase their skills and expertise. Regarding the patient's attitude toward the prescribing, as a clinician, I really find this helpful. So that would be nice if the results would be provided to the clinicians. And we know that they had different healthcare professional in that study. It's not very clear to me what was the degree of the pharmacist involvement. I mean, being a pharmacist and following these patients, it's sure that I'm wondering if it could be something that would be a good addition. So really, to me, what is a real challenge is also the interaction between the different type of population and what kind of intervention we put in place. So we have, if we target larger population with less complex, less medication, sometimes we can have an accessible intervention that is less intensive, but maybe the impact may be more difficult if we have that big sample. At the complete opposite, if we target more at-risk patient with excessive polypharmacy, frailty, Jerry syndromes, we'll probably need an intervention that needs a higher involvement, time, expertise, interprofessional collaboration. So really, what is the best balance? What is the degree of intervention that we should aim to allow adapted and individualized care? I don't have a perfect answer. I would be willing to have your opinion about that. We know that one size does not fit all, but how should we tailor these interventions? Then, if we look at the control group, I mean, we saw that there was a reduction of potentially inappropriate medication in the control group. So we know that deprescribing is a hot topic. So is it just, are people just getting better in terms of usual care? So I'm just wondering, how do we differentiate like a specific intervention to make sure that actually that it brings a care that is better than usual care? And that makes me think of I call the trospium case. They had a lot of patients being on trospium. So I'm just wondering, maybe there was already something that were targeted, because sometimes for some clinician, this one may seem less risky because it doesn't cross the brain barrier. So maybe to me, that's even if it's not perfect, to me, that's an indication that was there something electronic that were influencing the care. I'm just wondering what was going on there. And then for the outcomes, we know that the primary outcome were not significant, but I'm just wondering, what is the real target? Like for the total number of medication, we know that it's not reflecting the quality of the prescribing. And as we saw in Mrs. M, actually, when we do the medication review, it may be unchanged or even increased. Also, the percentage of patients with at least a potentially inappropriate medication. As a clinician, I find this number very difficult to change if there is multiple inappropriate medication, because that means we need to stop a lot of them, and it's not always possible. And I just want to say that Initially, the trial was planned for a result at 6 and 12 months, but in the article, they just gave the 6-month result. And regarding the secondary outcomes, I think looking at the dose reduction was quite interesting, but probably because the primary outcome were not significant, we don't have the secondary outcome results in the article. Then maybe a last comment on targeting the potentially inappropriate medications for cognitive impairment, like they looked at a specific section of the beers. So we just need to put this in context that when we do a global review of medication, because we know cognitive impairment patients have a lot of other conditions. So maybe sometimes it's not these medications that may be the priority depending of the clinical status, and it'd be something else that may be deprescribed. The thing also that would be good to have a bit more info is what is the real prevalence? Like for antipsychotics, we can presume that some were used inappropriately, like for behavioral symptoms of dementia or sleep, but was there patients with a psychiatric diagnosis? So just looking at a database, it's difficult to do the differentiation. For the H2 blockers, we know it was removed from the last beers list, being mainly in competition with the PPIs. So maybe the clinicians were less willing to prescribe these because maybe they were already an alternative to stopping a PPI on a patient. And regarding the opioids, as a clinician, stopping for chronic pain is often difficult. I should say sometimes we try co-analgesics, but co-analgesics have some limited efficacy. A lot of them are actually also potentially inappropriate medications. So the balance is really not easy. So what is the ideal medication outcomes? Like, is it the total number of potentially inappropriate medication? Should we consider not only beers, but also other tools? Should we consider, for example, a tool that consider the dosing, like the drug burden index? So that would be helpful to have a more global idea. And really my last comment before asking what is your perspective is this intervention at the beginning was designed to activate patients and clinicians, giving education materials. So I'm just really curious at the end, did the conversation about medication occurred when the patient saw the physician in the primary care clinic? So that would have been quite interesting. So there is a lot to discuss, and maybe it would be good to have everybody's perspective, but Emily, I'll leave you there.
Thank you. Thanks, Louise. That was such an interesting presentation. I really liked how you paired it with the case that you saw to try and get to the root of why the study was negative. So that's a lot to think about. We have some questions in the chat box. So there was sort of a general question about trospium and, you know, is it really better or is it bad because it doesn't cross the blood-brain barrier? So some discussion about how it's an anticholinergic. And so even if it's not affecting the CNS, there's maybe other side effects that are causing issues. So I have a question from Kinda Ibrahim here. Kinda, do you want to ask your question?
Hello, sorry, it's evening in the UK and my son is playing and he's very loud. So I think everyone can hear him. I've made some comments, but my question may be about the involvement of carers or family members, especially for people with cognitive impairment. How was the education targeting family members as well as patients, and yeah, how because there is normally it's lots of resistance from family to make decisions on behalf of the patient. So again, this is something I'm interested in, and how we can empower family members to make the right decision for the patients. Yes. So
yeah. I mean, I don't think there is one answer for that. I can just answer that the family or caregiver were also targeted, like the materials that was sent to the patient, but they were inviting the family to participate and in that. As a clinician, it's true that to me it's essential, especially for cognitive impairment patients, to have the family involved. And it's true that sometimes they may be reluctant, but a lot of them are actually, I find, quite open. And when we explain more the rationale in the background of deprescribing in terms of preventing adverse drug reaction or actually managing possible side effects that are already present. And usually in my experience, the family is actually, they are usually on the side of trying deprescribing unless they had very bad experience.
So there are quite a lot of comments agreeing with you about how to kind of score deprescribing, and that it really should include switching to a safer class, dose reductions, and that sort of yes, no stopping is missing a lot of the important clinical impact. Donna Bartlett is saying she loved being a part of this, went to go teach. Really, yeah, a lot of discussion about how to capture the best outcome for deprescribing. Do you want to comment on that a bit more, Louise?
Can you just repeat the comment, Emily? I
Yeah,
was trying to read at the same time.
How do we define deprescribing in the clinical trial, and how do we capture dose reductions and class switches? I can say from MedSafer, we actually had to go through and personally score the class switches and the dose reductions to say if they were deprescribing or not. So it was a massive additional amount of effort, but possibly worth it. Yeah,
I agree that deprescribing doesn't need to be defined only as stopping, but really dose reduction needs to be taken into account. And while doing some chart review, we know that sometimes it can be very complex.
So a lot of comments just saying what a great presentation this was. I think what we can do is, unless there's any more questions here, I'll show you in the next slide, which is when the next journal clubs are upcoming. Are you able to put that up, Cami? Okay, yeah, she's on it. We'll just move forward one slide. Here we go. So everybody, thanks for participating. This was really incredible to have, I think, close to 50 participants from around the world. You can see these are the upcoming international journal clubs. So there's one in December with ESCP, NERD in February, March, CADeN in May, June, and then US Deprescribing Network in September. So we do plan on having more of these. And then we can just go to the next slide. So I think some people were asking, is there a possibility of signing up for the next session? This is the link if you go back one slide. So you can take a look at that, maybe take a picture or screen capture that. And then we can go to the next slide. So I really want to thank the organizing committee, and in particular, Cami Gagnon and Nin Kwong, who made sure that today's journal club happened. But we are a big group of people from around the world who participated in organizing this. And then finally, the last slide, thank you to those who stayed. This is how you can provide us with feedback. And we do have a final poll. So I'll just launch that final poll. And thanks everybody for filling out the poll just to help us to improve for next time. If you have more questions for Louise or you have comments that you weren't able to share on the Zoom, you can also contact us at CADeN, and you may want to be involved in planning the future journal club sessions, or if you want to present a future topic, and we would be really happy to hear from you. So please contact us if you have any ideas for future journal clubs, or if you'd like to propose future speakers. Okay, thanks everybody for attending, and enjoy the rest of your night, your day, your morning, wherever you may be. Bye.